Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. This episode, we are chatting to a remarkable young emergency physician who is a perfect example of the new breed of EM physician, one that wears many hats and has fingers in many pies, all with the aim of improving the drivers of good health outcomes. Like many others, Dr Magano Akuaake did her undergrad and postgraduate training in a very different setting to the one she now finds herself working in and leading in. We chat about how she has adapted to her new role in a new setting, some of the remarkable innovative projects she is working on, including the Emergency Medicine Empowerment Africa movement, an ideas sharing platform. We then move on to Ukulele, an app that she has started that empowers patients to keep their own healthcare records. And finally, what she sees as the future of Namibian and African emergency medicine, especially with her experience of doing an MBA, as well as further education from Harvard about AI in healthcare. Without further ado, welcome to the show, Maggie. Thanks for taking the time to come on the podcast.
Thank you so much for having me. It's such an honor truly to be on this podcast.
Would you mind starting us off by introducing yourself and giving us a brief background of who you are and your professional career so far?
My name is Magano Akuaake. I think most people know me as Maggie. I'm an emergency physician and I've been practicing for just a little over a year now, back in my home country of Namibia. And it's been a roller coaster of a ride, one of true growth and learning. And it all feels like I've lived 3 lives in a really short period of time. I was raised in Namibia, just for background. I started off my medical journey by being medical diploma at the University of Namibia. I then went on to South Africa to do my undergraduate training in medicine at the University of Stellenbosch in Cape Town here. Ended up going back home to Namibia to do my internship. And at that point, I think I kind of already knew that I wanted to get into something that has a lot of adrenaline. So I started preparing for my primary internship. And just a little, like 2 or 3 weeks after internship, I was asked to run a 6-bed ICU by myself. And at that point, I think I recognized that most of the patients that ended up in ICU had their emergency not really well recognized or managed, whether it was in casualty or in the ward or in the outpatient departments. And that really prompted me to be able to go back to school. And I got accepted into the then combined UCT Stellenbosch Emergency Medicine program. And I think for many people who know the program, it's a rigorous program where every 3 months you rotate through general ICU, tertiary level ICU, emergency centers. You do pediatric ICUs, you do other specialty rotations like anesthesia and gynae. And I think my favorite was the pre-hospital or the EMS rotation where you get the response car and you get to see what happens in the pre-hospital stay. I graduated and came back home. And I think this has been one of the greatest challenges that I've ever faced, not only in my life, but emergency medicine at large. Practicing in a setting where emergency medicine is so very new, but it's allowed me also to delve into other spaces, for example, the digital health space where I've developed my Ukulele app. And if we have time, we can touch on that a little bit later. And I've been doing traveling in the last year where I've been teaching at conferences and symposiums, and I'm taking a little bit of a break from that to focus on my MBA in healthcare management that I'm doing this year and just implementing the invaluable lessons that I'm learning from this program into my own emergency practice. I have a few other passion projects, including Emergency Medicine Empowerment Africa, and also doing AI model development. And one of the things that I'm really excited about is my new appointment on the National Commission on Research, Science and Technology. I'm a member of the Technical and Advisory Board for Ethics and Responsible AI. So those are just a few of the spaces that I've really just been privileged to inhabit in this 1 year of being an emergency consultant.
Wow. You certainly are a busy lady. So congratulations for making the time to do all of those things. But I think we will touch on all of them throughout this conversation. Let's start off with just a general question about training in a setting where emergency medicine is established, such as Cape Town, and which is similar to many other settings or urban settings around South Africa and Africa to relative levels, and then going and practicing as an emergency physician where it is less well established. And there are many people that do that. What's been your experience, and have you learned from other people that have done the same?
So I think one of the big challenges in practicing or learning emergency medicine in a system that is already set up and relatively functioning well, such as that in the Western Cape, is that you get comfortable and that you really just are here to do the work and you get the work done well, and you don't actually start to look behind the curtain and see what actually makes the system function. And I think that's one of the things that I really struggled with, is that toward the beginning or just like starting off my work as an emergency physician, is that I was hit with the realization that there's no plug and play option. There's no just starting off the system that I was working with and plugging it back in a local context back home. And even though it's an African setting, social politically, it's completely different. And I had to now see how I'm going to develop this system from the ground up. And I wish that's something that I could have invested in more, or the programs could have invested in more, especially that they do have residents that come from across the continent where emergency medicine is not even recognized as a specialty. And we'll from the fact that people are going back home to actually one start the fight of getting emergency medicine recognized. But then also now looking at how do you do a situational analysis in reality, looking at your local population demographics, looking at your capacity of the nurses that you have, your infrastructure, what equipment do you have, and actually coming up or developing a strategy that is locally applicable to your setting and not to what the Western Cape or South Africa is doing, but actually looking at your own fund, looking at your own health system, looking at your own challenges, and then developing your own model according to that. So for me, I think I was privileged in that I had 4 emergency medicine physicians who had already gone before me. All of them have trained here on the Western Cape system. So I think we speak the same language and we have shared the same vision when it comes to emergency care systems. And they have done the groundwork of taking emergency medicine, recognize the speciality, and they are also now sensitizing the medical world to emergency care systems. And I really do stand on the shoulders of these giants and the work that they're doing in the bigger emergency space. And for me, it's just to actually get the groundwork done. So that is one of the things that I'm really grateful for, but not everyone is fortunate in that. And this does not only stand for emergency medicine, but for many other specialities, whether it's an anesthetist or a pediatrician, when they get back to their local settings, when they've trained in such a well-resourced, and I really do say South Africa is well-resourced setting, when they go back to their own settings, they struggle with that in that they don't get to practice the profession for a while just because they have to develop the system from the ground up before they actually get to do the work that they're so passionate about. Hope that answers your question.
Yeah, no, very well. That outlines the personal context as well as the situational context beautifully. For those or most of us listening won't be familiar, in a simplistic way as possible, what is the breakdown of the healthcare system in general, and then with regards to emergency medicine in Namibia? Is there a private-public divide? There's obviously an urban-rural divide, and then a pre-hospital and a hospital divide. And what does that currently look like in Namibia in a short summary?
So as I mentioned in the previous question, there are quite a few similarities between the two countries. And if we do have a two-tier system in that we have a public and private system, and I currently work in a private hospital, so I'm helping develop their emergency medicine space in the private setting. But Dr. Sikuvi and Dr. Gaudensia are pivotal in developing the emergency care systems within the public system. This is both at national level and getting it recognized, but also in the public sector. And actually, they are the ones who started the first emergency center within the country. And this is unfortunately still in the capital city. Emergency care hasn't really been decentralized to the regions yet. And that is the work that we have to do. And we still have to work on even the university recognizing emergency medicine and getting our curriculum implemented there, both at undergraduate and postgraduate level. So we're not doing any of that training yet, but it is part of the strategy in the next couple of years. And currently we are working on getting an emergency medicine association registered so that we will be able to drive this at a larger scale and not only centrally, but also be able to disseminate it to the regions as well as the local facilities to understand what actually emergency care is about.
Awesome. Thank you. With regards to one of your pet projects that you mentioned in your intro, tell us about the Emergency Medicine Empowerment Africa movement and what is the gap that you're hoping to fill and what is the aim for this idea and what have you done so far? This obviously touches on some of the themes that you've mentioned so far in moving back to your local setting, obviously, and that applies for a lot of people across the continent.
Yeah, so Emergency Medicine Empowerment Africa truly has been a vision of mine, and that has really evolved since I started thinking about it. And initially, it was a platform that I wanted for registrars because I got the vision while I was still registrar, where I wanted a platform for registrars across the continent to have a space to connect, share experiences, and just find mutual support. Because I wanted to know if, as a registrar, felt the same confusion and challenges that I was experiencing in the emergency medicine space during my training time. During my exam preparation, particularly, I started to notice that there was a very big gap with the resources that I was using. For example, the books, the journals that I consulted, the quizzes that I was using were mostly from the global north. And I must admit, look, they're really valuable. They really didn't reflect the realities and challenges, especially when it comes to resource limitations that I was facing. And the South African content is there, but it's also very limited and not very accessible, especially, that there is provincial divides, especially when it comes to these resources. And for the Namibian context, there's almost nothing that exists. So I really just saw the importance of sharing locally relevant stories, innovations, and solutions. And being at the conference, we get to see the vast amount of research that people are doing, but it is really hard to really come across these stories on the internet. And I really just wanted to create that platform to empower emergency practitioners. This now ranges from whether you're a medical student, you're a nurse, you're a doctor, you're a paramedic. I wanted people to have access to this content. So the platform is still in its early stages and we still have a long way to go. But I think at the moment, my bigger aim is just to highlight that there is a gap and to be able to encourage people to locally tell their stories and to foster a sense of ownership of African emergency medicine. So I truly believe in creating a table and not really just waiting for invitations for people to say, oh, can you come and share your stories? But let's create our own table and build this platform together so that we can really amplify our own voices. I'm grateful for the local collaborations that I've had with Caleb from Coffee and Cases, the Pair podcast team, Elias and Tulani, and also from you, and just starting to bring those podcasts onto the platform and actually getting people to realize that there is a gap and want to start expanding the content, whether it's through blogs, whether it's through case studies, people can start creating textbooks. And this is the platform that I really hope that people can access and continue to build as we grow.
Yes, and it's so important because, like you said, there is such a big gap between the amount of resources available from the global north and the global south, and much of the resources that are available are not applicable to many of our contexts or any of our contexts. It's so important that what we do have, and there is a lot of good work coming out of Africa specifically, and I think it is very important to showcase and share what we do have.
Definitely. And I look, as a medical student or as just a medical officer or an intern trying to navigate the space, you get to see that our discipline really goes through many disciplines, from pediatrics to gynae to procedural sedation, or even anesthesia. And many of these things can not only be used within the emergency space, like whether you're in the ward or the outpatient department. And I think EM Guidance has been one of those digital platforms that has really allowed people from across the world to be able to access emergency care information. And having that in one space in a manner that whether you are putting up a chest drain and you don't have all of the resources that you'll see if you go onto a YouTube video with scalpels and donning and doffing for the whole procedure, but people are doing it in a sterile manner in other settings. And it is important for us to be able to learn that there is actually a way to do this. And other people have managed to do it. Let us learn from each other.
Yeah, and I think, like you mentioned, emergency medicine is so translatable to so many disciplines that regardless if you want to pursue emergency medicine itself, a good founding knowledge of some basic principles of emergency medicine will stand you in good stead, whichever discipline you end up going into. Let's move on. Tell us about the Ukulele app and what that's about.
So Ukulele is, again, one of those things that was really born out of frustration, being on the clinical floor, where you get to speak to patients and they're not able to tell you their previous history. They'll say that I've had a previous surgery before my stomach, and they're like, Mama, you know how many organs are in your stomach? So they could have really operated on anything. And it really just speaks to patients, the relinquishing all of their responsibility when it comes to their health to doctors or healthcare providers, and not really taking any of that responsibility for themselves. Would in fact translates to them not being active participants of their own healthcare journey. So I really believe in patient empowerment, and patients should know their condition. They should know their medication. They should know their health history. And I just wanted to create a simple tool that allows people to have ownership and also become active participants in their health journey. So, especially in African setting, we know that we have our own challenger. For example, low literacy in terms of education level, but also language barriers, that you speak English to a particular patient and you're explaining things that they will not really understand for themselves. So it's important for patients to have this in the form of a discharge summary or just a simple word that they're able to take a picture of and go home and Google or get a second opinion. Even with patient consultations, they're like, as a GP, it's like 10 to 15 minutes at most. And in the emergency center, you know how rushed it is. You don't really have time to be able to explain the intricacies of something. So allowing patients to have that information, go home, digest it, so it's just a place where people are able to secure their records, take ownership of their health journey. And yeah, I think.
So just to clarify, it is a app where somebody keeps their own health record on their phone and then can present that to themselves or family or another doctor, and then that compiles a health record that they can keep with them essentially.
100%. One of the things that I think even you would have experienced is that you get patients who come from other provinces or from other countries. And especially for me, I get patients who come from other countries and they don't have any of their previous health records. And they're like, no, they did an MRI for me, or they did many blood tests for me, and they say there's something wrong with my blood. And that usually results in the health system now having to start off investigations from scratch and to be able to re-diagnose you and exposing you to further invasive procedure, increasing radiation. And with health tourism, it's one of the things that we really struggle with. So, especially in Namibia particularly, a lot of the patients end up going to the capital city for various investigations, and they get a small note that is written in a health passport that either gets lost in the ambulance or a taxi, or it burns down in a shed. But if this is available, one thing that every patient or most patients usually have when they come to a consultation is their phone. They guard it with their life. Being able to come back with that information and allow for entry or just a continuation of the healthcare journey for patients is very important. Or I really feel it's more important.
Yeah, and I think to add to that, I think a pivotal difference between the Ukulele app and current digital records is that when we see a patient, I know in the Eastern Cape they have an A5 counter book, and Zimbabwean patients also have a similar counter book that they use as a health passport. And when it is available, it is hugely helpful because everything is well documented and the patient keeps it themselves. And then if you move into a more digitized setting, often the digital platforms do not link up with each other. So people have different digital records at different hospitals, or different files at different hospitals that are available or that are not available when you need them. And then that is all lost. So I think often a well-kept manual record is much better in a lot of situations than a digital record that one cannot access or is scattered across many different IT systems. So this combines both of those problems. It firstly empowers the patient to keep it themselves and have access to that information, which is hugely important. And then it also counters the very common occurrence of all of that valuable information getting lost.
And what's interesting, I think, as with any digital innovation platform or app, is that what I intended it to be useful, and when we're looking at the analytics, is actually not really what it's being used for. And when I ask patients, it's actually they are actually using it more as a health directory, because there are the numbers are the different health facilities, both in private and in public, as well as ambulance services that are on the app. And that's what people are actually using. And the feedback is that when you Google any number or any healthcare facility, you usually get like an output of so many numbers, and you don't even know where to start. And some of them are very old. So patients are actually using it for that, to be able to contact healthcare facilities or emergency services. But then they are actually using it for the intention that we use it. And look, we take it as is, and we speaking to people like I know you know John Ray from Cape Medtech and William from Wula. They were also very instrumental in this journey of developing this app. They are really just about this. It's about the long game, and we've really just been in it for the last 10 months. And we're really just taking it one day at a time. And we are just hoping to see broader movement towards digital health solutions that are tailored to our context. And this doesn't take away from what the government is doing. And I know that for the past couple of years, they have been trying to implement an electronic health record system, and I'm really looking towards our new minister to seeing how she gets it right, because she's also very much for digital health. So yeah, I'm actually very optimistic of where we are in this journey.
Awesome. Oh, it sounds very promising. You recently completed a course on AI and healthcare from Harvard. Tell us a bit about the potential that you see in a place like Namibia for implementation and safe impact using AI in a system that has so much potential for expansion, as you've mentioned.
Oh, I think one of the biggest things that I've learned from this course, it was a great introduction, and it was a very rigorous program, and it was supposed to only last me 3 months, but it took a little bit longer than that because there's just so much information to take in. But basically the take home was that, especially within the healthcare space, we still have a long way to go before we can implement many of these AI digital tools, particularly because there are so many regulatory and ethical considerations that we don't take into consideration. So, for example, just using some of the AI transcription apps that I see some people using in the emergency phone calls, is that there we the only thing that is currently regulating these things, like the Copy Act, that talks to the patient's information and how we store it and how we keep it. And whenever
Yeah.
you use a
Yeah.
patient's voice or enter anything that's sensitive when it comes to patients, that can result in a particular patient being identified in any of these models, you actually don't know where
Yeah.
this information
Yeah.
ends up and what it is being used for. And we need to be put in clear ethical policies and regulatory frameworks to govern this, which we currently don't have, and we really need to work towards. And hence my active involvement in the responsible AI development, even with considering, I mean, I'm all for AI, but it's just that it needs to be done in a way that affects both patients and the doctor. And that's the other thing, is that when we look at some of these AI tools
Yeah.
and the differential diagnosis that they give out, or the recommendations that they give, you must understand that in the end, it is you who has the responsibility in
Yeah.
whatever you decide to implement. The AI tool can never be taken to court or any recommendation that it gives. And there's still flaws in that. You see,
Yeah.
one of the exercises we had was just writing up an electronic record, and you see how an AI model actually hallucinates many of the things within electronic health record. So
Yeah.
some of these things need to be brought out in an educational platform to be able to sensitize healthcare workers to the dangers of using AI, but it shouldn't take away from us moving toward embracing it fully. So yeah, I'm excited
Yeah.
for AI implementation. I'm working on my own AI model, but it's just a matter of just allowing people to know some of these nuanced things that we need to take into consideration. And if
Yeah.
we as medical health professionals are not actively taking part in the regulatory development of these, other people will do it for us, and it will actually not be as beneficial.
Yes, I think it is, like you said, it's got huge potential to help us in numerous different ways, but it is obviously a risk and a danger if it's not used safely and ethically. I think for now, the most practical use of it for a lot of us is more of a time-saving thing with the transcription apps and things like that, and perhaps a organizational thing, because a lot of our time that we spend as doctors everywhere is on administrative tasks, writing, um, booking things, filling out forms for this and that. And I think the short-term potential for a lot of AI to do that is very tangible at the moment. But in terms of the decision making, like you said, it's very important to understand that you are the one making any clinical decisions about everything, basically.
100%.
Then in your introduction, you also mentioned that you're doing an MBA in public health management. What is your opinion of people such as yourself who specialize in clinical medicine and the exams that you write are largely clinical based on the speciality that you're specializing in? And then once people become specialists, they, especially in less saturated systems like Namibia, you step into leadership roles very quickly. And the content that you have learned and prepared for in your exams is perhaps not as relevant as leadership, system management, and all of the other things that you are now branching into so well. What is your opinion of that divide? And do you think there's a need to address more of a leadership role in the postgrad training?
That's that's a really interesting question. And doing this MBA in healthcare management, a lot of people ask me why I do it and if I want to branch into business. And that's really not why I'm doing it. And even before I did it, I went to search and look at each of the curriculums of the different programs that are around, and just look for something that I'm looking for. And for me, I'm looking for the wisdom that I was not getting so much in the program. And to explain it, the program, the residency program is a master's in medicine. And that really is what you become. You become a specialist in emergency medicine, and you can handle any emergency even in your sleep. And this cuts across different specialities as well. So the medical management of patients, you become excellent at that. But as I alluded to earlier on, especially in the African context, when you go back, the medicine, you don't actually get to practice it because you don't have the setup or the setting to be able to practice that medicine. And you need to be able to advocate, and the different qualities that a doctor should have. For example, a clinician, you're a manager, a teacher, you're also an advocate. But advocating for your patient, you come with to your hospital board, or you come to HR or finance, and you are talking to them about patient outcomes. You want to decrease morbidity, mortality. You want to increase throughput. This is all terminology that another specialist would be able to understand. But when you step into the rooms that you're actually advocating for systems changes, you need to translate that into terminology that they're able to understand. And I've just been in this program for the last 6 months, but it has been a well of knowledge that I just keep drawing from, because one of the modules is human resource development. And when I speak to the HR consultant, I'm able to speak to the strategy that they have as a business, and use it even in any other setting, to be able to translate what I want for my staff, and be able to say that, look, for the emergency center, this is the strategy that I've developed for the next couple of years, and this is how I want to move our HR capacity, and this is how it will align with your HR strategy, and this is how we can do together in terms of getting them trained appropriately, the various courses that we can offer, the training or teaching institution that we are currently building within the hospital. And also with finances, I just can't rock up and say I want a blood gas, but I need to be able to translate that into a financial model that the finance guys will be able to work with, and also with strategy development. So when I speak to the specialists, or even just the GPs, one of the things that when you come into the space, you are usually just inundated with a lot of problems. You're like, oh, the intern did this, or the blood gas machine isn't working, or the newspaper published whatever article. So you really get fixated on just fixing problems, and you don't learn how to develop a strategy for your emergency center and work towards actually building up and uplifting, whether it's an emergency center, department, your practice. And those are the things that I am really getting to learn to sit down and actually analyze my emergency department, looking at its strengths, its weaknesses, what opportunities do we have, what are the threats that could actually cause this emergency center to not function optimally. Developing KPIs from that and actually saying, okay, guys, how are we going to strategize? And actually have good output to be able to say at the end of the year, guys, I'm so proud that these are the things that we have done and we continue to move next year. Let us take another chunk. We have a big elephant, but we are just eating it a chunk at a time. And that is reasonable, that is feasible, because coming in as a young emergency consultant, I just had all of these ideas on, oh my gosh, I should, and we should also, but actually just bringing it down, bringing it into bite-sized pieces and seeing, okay, we are going to develop a strategy in the next 5 years and just eating a small piece of at a time. That really helped with the resistance, but also managing the change. And there's also like a clear template on how this can be done and various strategies that you can use to manage the change in a system. And it's really just in 6 months, but it has transformed the way that I function as a leader and has calmed me down significantly from the junior consultant into a junior consultant pro max kind of something where I'm a little bit more calm in my approach to how we're going to transform emergency here within my small setting before I'm able to translate it into other settings.
That's incredible. And I think that speaks to a lot of the themes and a lot of the other guests that have spoken on this podcast, to understand how different people from different sectors think, and what motivates them might not be what motivates us. So to find that common language is hugely important in getting what we need done, actually done. To move on to the last question, and this might be difficult for somebody wearing so many different hats, but they all seem to combine into one big hat. If you had a magic wand and could materialize anything for or either Namibian or African healthcare on the spot, what would that be?
If I had one word, it would be to have a collaborative emergency medicine community across Africa, where the different stakeholders from different countries and backgrounds really just support each other openly. We share the solutions that we're coming up with, any ideas and anything that we're working with, because many of the struggles we face are really shared. Our systems challenges, the resource limitations that we have, and even with the training gaps, they really cut across borders. And if we could really work together to develop these context-specific solutions, it would result in an emergency medicine space that is sustainable. My dream is to have a place where doctors, nurses, paramedics are sharing ideas despite the borders that we have. So I am fortunate in that starting off my emergency career, I even until now, whether it's at 3 a.m. in the morning, I'm able to call any of the other EM physicians in the country and they're able to give me advice, whether it's clinical or admin. And I wish that we could have that type of emergency medicine family where we have peer advice. So yeah, I'm hoping that Emergency Medicine Empowerment Africa does develop into the hub where we have really a repository of content, whether it's stories, case studies, protocols, podcasts such as these, blogs, journals, and again, educational resources and system development and protocols and forums where we can actually discuss the challenges that we are having in a non-judgmental manner and in the spirit of Ubuntu. And in Ubuntu, we say that I am because we are. So yeah, that would be the one wish I would have. And in the spirit of Ubuntu, and in Ubuntu we say that I am because we are. So yeah, that would be the one wish I would have.
Thank you. And I think it shows a lot about your personality and ambition that you are actually actively doing something to make your wish come true. So congratulations.
Thanks so much, Dan. Thank you for having me. This was a lot of fun.
That's all for this episode. To summarize, we chatted about emergency medicine in Namibia and what it's like to translate skills between different settings, as well as the translation of learned clinical skills into leadership and managerial skills depending on the position that you find yourself in. We also spoke about Maggie's pet project, Emergency Medicine Empowerment Africa, a wonderful platform for connecting with like-minded people across the continent. We then spoke about her app, Ukulele, which you will find a link for in the show notes. I hope you enjoyed the episode. We certainly did. Be sure to review and subscribe on all of your main platforms and to send to a friend or a colleague who might be interested. If you want to get in touch, find me on LinkedIn or email me at dan@badem.co.za. Please also follow us on Instagram and Facebook at Brave African Discussions and X or Blue Sky as Bad EM. Thanks for listening. See you next month. Bye bye.